Hello, everybody, and in today's lecture, we're going to talk about understanding prescription insurances. Now, I know that in the entrepreneur class, it's not required, especially if you're continuing on for your business plan, to have a traditional pharmacy. You can, develop, and depending upon what business plan you pick, we'll discuss the various different ways that you can make revenue and bring that in. We talked about in Pharmacy Practice 6 different ways to bill for clinical services. That might be something that you're thinking about. But today's lecture, we're going to focus on if you own a traditional community pharmacy, what are the components you need to know about understanding prescription insurances? Who are the players in community pharmacy? So one of the things, if I'm starting a community pharmacy business, I need to know where am I going to bill for my services, and especially for my distribution of medications. Where all community pharmacies get paid through third-party insurances is what's called pharmacy benefit managers. And pharmacy benefit managers are that middle person. That is the person who is going to process the prescriptions, verify people's insurance, verify they have coverage, and then they're going to be the ones who are going to pay us. They're also the ones that they will audit us to make sure there is no prescription drug fraud. And this is a snapshot reported from IMS, who does every couple years reporting on the entire industry of medicine. And so, although this is a 2013 snapshot of the PBM market share, it really hasn't changed over the last 3 years. The biggest PBM, which stands for Pharmacy Benefit Manager, is Express Scripts. The second one is CVS Caremark, and there are various other ones you see on the other side of the pie of this representation picture. Now, Express Scripts and CVS Caremark play a big role, but all these other ones also may be implementing. And so, depending upon when you are starting your pharmacy, community pharmacy, you'll want to be able to set up contracts with the various PBMs. How do you do that? Sometimes your wholesaler can help tie you into these companies called PSOs, and these PSOs actually work for you. They try to negotiate and get you into the multiple insurances. And so a lot of these smaller PBMs on the side work for various PSAOs. Express Scripts and CVS Caremark, sometimes depending upon what type of entity it is, they have both private plans and Medicare plans and even Medicaid plans. They may make you do individual contracts directly with your pharmacy. What the PBM is doing is it's working for the true payer. The true payer may either be a health plan, it could be Medicare, it could be state Medicaid, it could be an employer group. And what the PBM does is it helps create the network. It helps sign up pharmacies who want to participate. It develops the contracts on how pharmacies are going to be reimbursed. The other thing that PBMs do is they're the ones that create the formularies. They're the ones that also verify, prescriptions are legit. And because the ultimate person who's paying for these prescription drugs are either the payers, Medicare, or an employer group. So, for example, a large employer group can actually, you know, subsidize out their, or not subsidize out, they can bid out their services. And so, for example, somebody may have Aetna for their medical, but they use CVS Caremark for their prescription plan. And so larger employer groups can do that. Small employer groups usually have to go with one type of commercial plan. So, for example, if your community pharmacy wanted to offer health insurance, you're not large enough unless you become a multi-store chain to be able to do that outsourced bidding. You actually have to get all your prescription coverage and also your medical coverage through one entity like Highmark or UPMC. That's an argument for another time, but that's one of the things that we talk about in terms of fair practices to help small businesses, but we can discuss it another time. One of the things, I should have a slide up here, but I apologize I don't, is that when I'm billing in insurance, and for talking to a lot of you, you have worked community pharmacy, is when you get that prescription card, you see various numbers on it. The first one is the BIN number, and that BIN number actually represents which PBM I need to bill to, and also what health plan is that PBM representing. So, for example, Highmark and UPMC both use Express Scripts as their PBM. However, UPMC's bid number is 00378, I believe, and Highmark's is 610014. So that determines when I build that out, that PBM sees, okay, this person either has Highmark or UPMC. The group number can represent the company that they work for. The group number can represent the difference between a commercial plan versus a Medicare plan. So, for example, if it's a Medicare or Medicaid plan, UPMC uses PD, PDM for Medicare or Medicaid, and PDMC for commercial. So that's the different ways to determine how that change. And obviously, the other player in community pharmacy is the patient themselves. And the patient themselves in 2016 and beyond have been having to pay more out of pocket due to that they may have high deductibles they have to pay before the prescription insurance kicks in. A lot of the health plans we'll talk about later have what's called tier plans, and these tier plans can determine whether or not a prescription is a preferred brand, non-preferred brand. And so you are always representing your customer and your patient and helping them in terms of saving drug costs. One of the things we see, the trend in outpatient pharmacy, was we have seen a growth in prescription drugs over the years, and so that's why community pharmacy is still alive and well and will be for many, many years to come. So, you know, you know, one of the things to talk about and take a look at here is that community pharmacy is going to be filling many, many prescriptions, but the ultimate goal to stay in business is to be able to have access that your patients can use your pharmacy, also that you have good reimbursements that your pharmacy can stay profitable and stay in business. Just a snapshot of who is getting prescription drug coverage and using third-party insurances. Obviously, since the implementation of Medicare in 2006, and because it's ultimately going to happen as we get older, we're more prone to disease states, more prone to take more medications, is your Medicare population is going to be your highest population. However, there is still pharmacies that can hold a niche in either pediatrics or in for those looking for health and wellness in the middle, between 19 and 64 years of age. One of the things too, if you look at the history of the way prescriptions were paid, that if you go back, 40 some years ago, the majority of patients were paying by cash. Prescriptions were not that expensive, and a lot of employers did not offer prescription drug coverage. The the main ones in the 70s and early 80s that did have prescription drug coverage usually were your big unions, you like United Mine Workers, United Auto Workers, United Steel Workers. The other one that stayed consistent over all the years is Medicaid, which is obviously, Medicaid is funded both by state and federal funding. When we got into the late 80s, early 90s, that's when we saw managed care, and that's when we really saw the growth of PBMs. This snapshot picture comes from an article called Recent Economic Trends in Outpatient Pharmacy and Recent Trends in Economics. It is an older article. It's a 2009 article. I posted that article plus a 2006 article. I do recommend you to read them. Even though they are several years old, they're very insightful to tell you a lot about how PBMs operate and how our payment system occurs. Obviously, since 2006, we've seen a bigger growth in the Medicare D population. If I take another snapshot from IMS, this is looking at that, commercial still, third party still dominates a lot, but the second one is Medicare. And over the years, with the expansion of Medicaid, we have seen that growth too. But the big issue that we face as a country, and where you always want to stay on top of what's going on and the changes in healthcare, is that how are we going to pay for Medicare and Medicaid in the future due to some of our tax revenue is not going to be the same based on population growth in our country. And that is why this is always, you hear the term entitlements in the political arena, that is why it's always being discussed of how's this model going to look. And so as pharmacists, we always need to stay on top politically of what's going on in the healthcare industry. And I recommend, if you're not a member, if you're looking into being in community pharmacy, independent community pharmacy, is getting a membership in the National Community Pharmacy Association and getting a membership in the Pennsylvania Pharmacy Association if you're going to reside in the state of Pennsylvania. If you're not going to reside in the state of Pennsylvania, then you should belong to whatever state association that you're going to reside. Both these organizations do a very good job of keeping you informed and up to date of what's going on in the healthcare world. The other thing that has changed over the years is patients do pay more out of pocket for their prescription drugs. A lot of the times this can lead to maybe not getting the right drug that they need because they can't afford it, not being able to, or trying to stretch your dollar and being non-adherent. And so, one of the things of why copays exist is there should be a shared risk for people to appreciate value. But the question is, in a society, what is that pain where it doesn't affect them not wanting to take the medication because they can't afford it? So a lot of times us as independent pharmacy is helping those patients make those decisions and trying to find that win-win, something that they're going to be able to afford to pay, something that we can fill for them, and something that we actually will make money on and still be able to help our patient and customer. One of the other things that PBMs do, we'll talk about this a little bit later, is they help control drug costs by formularies, but within those formularies they may have quantity limits of how many drugs of a certain medication you can get per month per every 90 days. Medicare has these requirements too. So for example, blood glucose strips, depending upon if you're insulin dependent or non-insulin dependent, will determine how many times a day you can test. Some drugs require prior authorization. They want to have more medical documentation showing that this drug may be a high expensive drug, not applicable to all patients, that patient meets the requirements. Some things such as step edits, which means that before you try this drug, they want you to try this drug first. And then the other thing is controlling how often a person can get the prescription filled by refill too soon. Because of all these different implementations, unfortunately, it can be very confusing to your patient and consumer. And so a lot of times patients may just decide not to get the medication filled, or even though it's filled, never to pick it up, which is called patient abandonment. And so us on the community pharmacy level are constantly dealing with how do we deal with, adherence issues. So trends that we've seen over the last couple of years is that healthcare has changed in, the way plans are laid out in terms of deductibles, copays. Patients seem to be paying more out of pocket for their healthcare needs. There has been a real focus on chronic care management, and so pharmacy, if we ever get provider status, may play a bigger role. And we're constantly helping our patients being able to afford their medications at the same time for us being able to manage our inventories and making sure our contracts are profitable enough that we can stay in business. One of the things we have to do when we get into about financials after this lecture is we have to look at how do we implement workflow into our community pharmacy to make us more efficient, to help our patients, to help prevent med errors, and also to help control costs. So we've done this by different ways. We've done this by streamlining our input process. If you're purchasing a community pharmacy or already have one, you may purchase software so the patients can either call in what's called an IVR system where they can punch in, leave a voicemail, or punch in their refill numbers. Internet refill, that you have a website that you can actually reorder your medications via the internet. And then also, too, you would sign a contract with a company known as SureScripts, which is the national company that helps implement e-prescribing to community pharmacies from physician offices. Depending upon the volume of your store, as you grow, you may want to get into automation to help provide more efficiency, prevent med errors, and free up your pharmacist's time to maybe do additional clinical services such as immunization or MTM. So you would, the other thing is obviously it's a must to have fast internet to be able to adjudicate claims to make sure prescriptions are being covered. The output side, one of the things that happens besides billing for that insurance, you have to make sure that you are recording that the signature log that the patient is picking up their prescription. If you ever go through a prescription uh, plans audit, they will look at things such as a copy of the hard script. Things that pharmacy has done to help streamline this is they have scanning. They've been scanning in all their prescriptions unless it comes in electronically. The other thing pharmacies do is they record electronic logs, which can be done through your point of sale system. This snapshot kind of looks at what the everyday occurrence happens in the community pharmacy sector. And so here's our pharmacy benefit manager. And once our pharmacy benefit managers roll, they contract with a payer. And that payer could be a health plan, that can be an employer group. And what that PBM does is they set the network, they set the contracts of what's going to be reimbursed. The pharmacy goes to apply to that contract. Sometimes they're allowed to be in the network. Sometimes they may exclude them out of the network. Unfortunately, a lot of times the contracts are non-negotiable. It's a take it or leave it type of contract, but you want to be in that contract to service your patient. The PBM, depending upon where the payer's employees are located, the they're looking for pharmacies to be able to do that. So contracts can vary depending upon region. You actually see higher reimbursement contracts in more rural areas than you see in urban areas. The other thing the PBM does is it sets formularies. So when I go to bill out for the patient, it'll tell me if it's covered or not covered. It'll determine to me what the copay is. The pharmacy benefit manager, to help offset costs for the payer, will negotiate with the manufacturer for what is covered and what's not covered. The other thing is on the pharmacy side, we are working with our wholesalers to get the best products that they are good products, but they are also the cheapest products, so that when I bill out to the insurance and then the drug that I've bought, that I still have a profit. The drug wholesaler then also, to help give me that good cost, is constantly negotiating with the manufacturer for those rebates. There are sometimes, though this doesn't occur as often as it once did in pharmacy, where you may buy directly from the manufacturer, but most of the times we're using the wholesaler who can buy in larger volumes to help us saving cost. And then obviously the patient themselves are impacted by all of these, by drug shortages, by PBMs restricting what drugs are covered or not, by their payer determining what formularies they approve that the PBM suggest, and then also whether or not, if they're a cash paying customer, can they afford what the pharmacy is charging. So there's a constant cycle that's always going on in this current distribution view. I'm not going to go into too much detail in this next slide, but there's so many different ways that we try to determine how do we get paid. I'm going to give you the basics in the next two slides of how we get paid, but please, this picture snapshot comes from that recent economic trends article. And the one thing about the United States system of how we get reimbursed for drugs, the question is, there's so many different prices for one single drug. And so what this pharmacy may purchase it for, depending upon what the wholesaler gets them for, the PBM gets discounts, and then sometimes the PBMs own their own mail order pharmacy or specialty pharmacy, which is in direct competition with the pharmacy that they're contracting with. So it's a very convoluted type of system. I wish to be honestly to tell you that it's a more simple system, but I can also tell you that pharmacies are still staying in business. They still got to fight the fight to make sure that reimbursement's good, but there's still a good future for pharmacy, because as you saw from several slides before, people are going to need prescription medication. We're not curing disease. Most diseases, we're managing diseases and streamlining that to the patient. There's an article that I posted about how payment occurs. And so some of the various terms you hear is you hear AMP, which stands for average manufacturer price. Another term is called AWP, the average wholesale price. And so these prices reflect of what is the wholesaler purchasing from the manufacturer and what is the pharmacy purchasing from the wholesaler. Usually what will be recorded in your pharmacy system from what you purchase from the wholesaler is your actual acquisition cost. The other thing that you'll have in your system, which is called AWP, the average wholesale price. That's not on this slide, but what the average wholesale price represents is that is what the manufacturer releases is that's the average price most independents not and chains are buying from buying from their wholesaler, and that AWP is kind of what we determine for contract reimbursement currently today. Usual and customary price, if a patient came in and was paying cash, that is what you would mark your drug up for the patient to be able to pay. This is an example of a contract. Unfortunately, over the years, we have seen reimbursement rates continue to decrease. But like I said, if you are, one of the things we're going to talk about over the next couple of lectures is how to manage finances, how to analyze your business, and a good business person today can still go into business for themselves and take care of patients. If you look at most independents today, still 92% of their revenue come from prescription drugs. However, that trend may change over the years with the implementation of immunizations, MTM services, other clinical services you may eventually incorporate into your pharmacy business, and would bring in revenue from other streams besides PBMs. If you also look at the way traditional chains, they're very close to independents, although they have a bigger out front. A lot of independents could have an out front, but there's a lot of independents that are just traditional apothecary stores where there are only so many square feet, where they have a few OTCs, but their main drive is prescription drugs. Your mass merchandisers like Walmart and Target, if you take a look, they're only 6.3% of the business, but these are the ones that they don't, not that they don't care. There's very good pharmacists in these businesses, but their stake of the game is selling other products in their store, and they're using pharmacy as more of a draw to their business than that is their business, and that is why you see gimmicks such as free antibiotics or $4 prescriptions. So how does a pharmacy get paid? This is an example of a contract of a Medicare D plan. So they would take what that AWP is. They would take 15% off of it, and they'd pay me $1.75 as if that was a 30-day supply. For 90-day supply, they take a little bit more off and pay me a little bit less in dispensing fee. And their argument is that less labor has to go into this because I'm only doing it every 90 days. Traditionally, these contracts are very similar. They've gone down a little bit in percentage, but most pharmacies today buy brand drugs a lot of times about 19 or 20% below AWP, and most pharmacies are buying generic drugs anywhere from 30% to 50% below AWP, and that is always constantly changing because the market's always constantly changing. And so constantly we are having to make sure we fight for maintaining reimbursements and also making sure we're purchasing our products efficiently. Because the other thing that doesn't, a lot of people, why $4 prescriptions, in my belief, doesn't really cut it from a pharmacy operations. And if you look at most of your traditional chains, they don't offer $4 drugs either, is that there is a cost for dispensing. There's your inventory that you have to maintain. There's your pharmacist salaries. There you got to pay for lighting, computer costs. And so NACDS and NCPA did a study several years ago, and they found that the cost for dispensing falls anywhere between, $10 to $12. And so you have to make sure that you are keeping those costs under control in purchasing. We've also seen over the years, although this is leveled in 2016, an increase in generic pricing, which sometimes can offset our revenue also. A couple terms to remember just to kind of, you might be familiar with, is a lot of patients may have initially a deductible, so even though you bill their insurance, it may come back that they pay either the full price for it or significantly a little bit more than they would if they meet their deductible. A lot of your pharmacy systems, when that reconciled claim comes back from the insurance through the internet, a lot of times you can actually go in and look to see where your patient's deductible is. Copayment is the share that a patient has to pay, and that copayment can be based on their health plan, whether they're a Medicare or Medicaid plan. It can also be based on whether it's a branded generic or a preferred brand or a non-preferred brand or a specialty drug. I already discussed what a PBM is. Um, in 2003, we passed the Medicare Prescription Drug Improvement Modernization Act, and so in 2006, we now have the Medicare D plans. I told you what AWP is. It is that number that gets produced by the manufacturer stating what they believe most wholesalers are purchasing and selling the drugs to pharmacies. And although that is not the real number you're purchasing, a lot of times that's what we're doing that. Some contracts will be also use the terminology called WAC, wholesaler acquisition costs, and that's it differs a little bit from AWP. It might be a little bit different, and that's the real big argument we have in our country is what is the best way to pay or to bill out a drug. There's another one that's been pushed by the federal government, and that is using AMP. If you go back and look at the articles, there's some pluses and minuses of using AMP, but currently right now, the way the system's working is AWP and WAC. What MAC stands for maximum allowable cost. So, for example, if a generic drug, when a generic drug comes out from the manufacturer, usually that manufacturer has a 6 month exclusivity to be the only generic company out there. And so the drug price doesn't usually come down in the first 6 months. And that's why you also see sometimes third party insurances not paying for the generic right away and still continue the brand. Once that 6 months exclusivity is up, then multiple other manufacturers can make that drug. And when those multiple manufacturers make that drug, that allows for um, that allows for um, the price to go down. However, say that Teva makes a brand, Dr. Reddy makes a brand, and say that Mylan Pharmaceuticals makes a brand. One of the things that a lot of PBMs do is they create what's called a MAC list. So there's a multi-source generic out there. What they do is they determine what that average selling price of that multi-source generic is, and then they come back to the contract and say, I know there's 4 different companies making, say, amlodipine, but this is our set price that we're going to pay. So regardless if I bought Mylan, Teva, Dr. Reddy, they're only going to pay me that set rate. And so as a business person, your job is to get in the cheapest generic so that you're not going to lose money based on that MAC price. And unfortunately to the consumer, that is why a lot of times you'll see if you work community pharmacy that constantly our generics are changing because the price of generics change constantly, and unfortunately there's no law that says that every generic has to be the same shape, size, and color, and so that can be confusing to your patient because their drug size and shape can change from time to time. Usual and customary is what I would be charging them if I had cash. A lot of times nowadays, most pharmacies may have some type of set pricing of how they price out their cash. Most of the time, the way their formulas will work so that they can cover that cost of dispensing, that they're competitive to maybe others who are selling for cash. And then the other thing is you always have to make sure your usual and customary is not below what you're being reimbursed by a plan, especially a Medicare or Medicaid plan, because if you're selling your drug cheaper but getting reimbursed higher from a Medicare or Medicaid plan, that's considered Medicare fraud. And so you have to make sure you're setting up your pricing in your system to reflect that. Other things, as I said, is that we will be constantly processing prescriptions. We will bill out private insurances, Medicare D insurances, and here in the state of Pennsylvania, we have the PACE program, which I'll explain here shortly. The PACE program acts as a co-insurance to Medicare D, depending for those who may meet, certain financial hits. Manufacturers sometimes, to help offset the cost of their drug in different tiers or copays, will offer those, and you will actually be billing out to the manufacturer coupons, which are usually handled by some type of PBM entity. Remember, manufacturer coupons unfortunately cannot be used for Medicare or Medicaid patients because under federal law, those are considered an enticement to use that product, and so they're considered a Medicare kickback. Medicaid, too, here in the state of Pennsylvania, a lot of states have contracted out to private companies. And so, even though Medicaid is paid by state and federal dollars, they'll contract out to various um, commercial plans such as Gateway, UPMC, Coventry, RX America to cover Medicaid. No matter what, you'll still be processing them electronically. You'll still be using a PBM that'll be setting those rates. As I said before, in 2003, we passed the Medicare Prescription Drug Act, and in 2006 it was implemented. So, kind of give you a an oversight of Medicare 101. Remember, Medicare Part A, which we probably really won't be dealing with. Medicare Part A covers hospitalization. However, Medicare Part A does cover some up to 100 days of long-term care. So if you would get into the long-term care pharmacy business, you wouldn't be billing Medicare Part A directly, but nursing homes that take Medicare Part A as reimbursement are responsible for paying for the drugs, and so you would be working directly with a nursing home, and a percentage of your billing would be direct billing to the nursing home themselves, not a PBM. Medicare Part B covers it's the supplemental insurance that covers physician visits, durable medical equipment, blood glucose strips, certain drugs such as nebulizer solutions, certain cancer drugs, our immunizations, a lot of them outside of Zostavax, which is the shingles vaccine, is billed under Medicare Part B. And as I mentioned before in prior talks, the checklist talk is that you would probably be applying for a Medicare Part B provider status so that you can bill those various entities, and those reimbursements can be done online also, and there's various different companies to help you bill that out. Medicare Part C is what's considered a Medicare Advantage plan. Medicare Part C was actually created in the 90s, and what it is somebody, when you retire, you are guaranteed Medicare Part A, and most people buy through that's taken out through Social Security a supplemental Medicare Part B plan. But if you don't want to have to deal with high deductibles and not showing what your copay is, a lot of people opt for Medicare Part C Advantage plans, and they're sort of like a one-stop shop where they'll cover both the medical, inpatient, and outpatient, and they'll cover the prescription drugs. Now, Medicare Part C plans have to follow Medicare Part D law in how they're implemented for prescription drugs. So, for example, UPMC for Life, Security Blue, Geisinger Gold, those are Medicare Advantage plans. And then if somebody doesn't want to go with a Medicare Advantage plan, they just have their traditional A and B, they then will pick a Medicare Part D plan for the prescription drug insurance. Even though the goal is by 2020 to close the donut hole, we still are dealing with a donut hole. 2016, if somebody was purchasing a Medicare Part D plan, this is how it looks. They would pick a plan. Depending upon the plans, there are basic plans, middle plans, and Cadillac plans. And so the basic plan that is what I have listed here in this slide. If somebody pays a middle plan or higher plan, they may not have an initial deductible. They may have set copays, but pretty much they are paying for that. They're just paying for it more in a higher monthly premium. So most people will pay a monthly premium that can range anywhere from $15 to $50 a month. If they go with a Medicare Advantage plan, that premium is included as a one-stop shop. That can be anywhere, depending upon if they receive subsidies, $90 to $200 a month. But in the basic plan, what will happen? The patient would pay the first $360 out of pocket. Once they pay that $360, they usually pay 25% of the cost of the drug. But like I said, there's a lot of Med D plans out there that people pay a little bit of a higher premium to have set copays. And so there's set generic copays for preferred, and there is non-preferred generic. So, for example, Highmark has a plan that you can purchase, a Freedom Blue plan, where you pay $3 for cheap generics preferred. You pay $8 or $12 for more expensive generics. You pay $47 for preferred drugs, and then you pay 25% of the cost, 45% of non-preferred brands. So there's various different ways that's out there. The one thing that doesn't change with all of these plans is the donut hole. And in 2016, the way it works is once I spend total drug costs. So maybe even though I pay $25 in copay for a $100 drug, Medicare is counting that $100 for my total cost. When I reach $3,310, then I am responsible for paying 45% of the cost of the drug until I spend an additional $4,000 and get to the other side of the donut hole. And if I do get to the other side of the donut hole, then I pay from, you know, anywhere from $2.95 for a generic or $3.60 for a generic, or 5% of whatever the copay is. Some patients here in the state of Pennsylvania fall under what's called the PACE program. And the PACE program has been in existence here in the state of Pennsylvania since 1984, and is actually funded by our state lottery system. It's based upon your income. Why this is good? It differs from the federal level of how they determine whether or not you receive assistance. On the federal level, not only do they look at your um, yearly income, but they look at your total assets. And so somebody may only make $12,000 a year in Social Security, but maybe they have $200,000 tucked away in assets, and so they don't qualify for federal subsidies. Whereas the PACE program looks at it year to year, just your yearly reported income. And what the PACE program does is acts as a secondary insurance. So the traditional PACE program, there's the salary numbers, and if they qualify, what happens is the PACE program will actually help them purchase a Medicare D plan. The Medicare D plan will be their primary insurance. You, the pharmacy owner, would bill the primary first. Whatever that copay comes back, say it's a generic and the copay is $25. Well, then you would bill that out to the PACE program, and that would come back as the max they would pay is $6. The advantage of the PACE program too is it helps cover the drugs during the donut hole. So the max somebody would pay $6 for generics or $9 for brands. PACE also does cover some drugs that are not covered under Medicare Part D. Certain vitamins such as folic acid, vitamin K for Coumadin, ferrous sulfate, aspirin, those aren't covered. Sometimes PACE will pick up those, and sometimes excuse me, and sometimes PACE will pick up um, other drugs that may not be covered under the primary plan. PaceNet follows the same thing, is just you pay a little bit more out of pocket, and PaceNet people will actually pay a monthly premium at their pharmacy to enroll into PaceNet. The last thing I want to talk about in third party world is the formulary management. And although this is not really a business thing, this is more just for your knowledge, that all PBMs will create formularies. And those formularies will try to cover every type of drug class, every type of disease state. If there are a commercial plan, obviously the employer sometimes can have the final say of certain drugs that cannot be covered. Medicare D has certain laws of pretty much all drugs need to be covered, and so does Medicaid. One of the things that formularies goals are to do is to help maybe improve quality prescribing, so physicians aren't just prescribing anything for somebody for a disease state. They're not writing doses above the recommended manufacturer recommendations. The disadvantages is that sometimes they may only be looked at as a cost savings versus what does the patient really need. One of the things that we've seen over the years is third-party formulary management, um, that they've used different steps. And so there's prior authorization, step therapy, quantity limits, and copay drug tiers. Prior authorizations are usually drugs that may require, certain, medical findings to be able to be covered. So, for example, a prior authorization may be required for using a COX-2 inhibitor like Celebrex. Even though it's a generic, the insurance company still may require a prior auth. So what are the requirements for that to be used? Well, they may need to show that, one, the patient has a history of GI bleed, two, they failed two other NSAIDs, and three, maybe they're elderly. Other prior authorizations might be that people may not cover certain antipsychotics without having a true psychiatric diagnosis. Step therapy is a little bit different. Step therapy is designed to help kind of do it, take it from a different angle of prior authorization. So step therapy, usually what it does is require somebody to try one drug first before they'll cover a second. So for example, in asthma, the gold standard is an inhaled corticosteroid. The other option in asthma is a combo drug like Advair, which has salmeterol and which is a long beta 2 agonist and an inhaled corticosteroid. So maybe somebody comes into your pharmacy, they've been newly diagnosed with asthma, and the doctor wrote for Advair. You go to fill the prescription, and the Advair is rejected. It says must try an inhaled corticosteroid first. So you call the doctor, the patient goes back to the doctor, you get a prescription for, say, Flovent. So say the patient uses it for 30 days and their asthma is still not improved, they're still having nighttime symptoms. So they go back to the doctor, and the doctor says, here's an Advair prescription, take it into the pharmacy. If it needs a prior auth, I'll do a prior auth. But when it comes into the pharmacy and you go to fill it, it actually is covered. And what it is they recognize that the patient did try this drug first, and so now they'll cover this drug. Quantity limits are depending upon certain drugs. Some of your migraine medications, such as your triptans, it's not recommended to take them every day. So, from both a safety and a cost preventive, they'll only cover maybe 9 or 18 tablets per month. And if they are going to use more than that, it would require a prior authorization. Some of your erectile dysfunction drugs, like Viagra, Cialis, they'll only cover so many tablets per month. Copay drug tiers is another one. And one of the things is, just to share with you, there's lots of different, I have here an example. There's a company called Fingertips of Your Formulary. It's a web-based company, but there's several different companies out there that you can actually go on and find out what does that primary plan cover, what are the, what drugs are prior authorization, what drugs are step therapy, quantity limit, and you can help your patient, and you look for that win-win for that patient. Tiers, all right, and so there's different types of tiers. There are 4-tier plans and 5-tier plans, and what they mean is what the patient's going to pay out of pocket. Now, the patient should understand what their drug benefit is. Every drug benefit can vary and differ, but usually if it's a Tier 1, it's usually the lowest copayment, most generic medication. A Tier 2 is a preferred brand. A Tier 3 is a non-preferred brand, and a Tier 4 is a specialty drug. So, for example, say that I get hydrochlorothiazide filled. That's a Tier 1. Maybe my copay is $4, or the max is going to be is $10. I then also may require a brand drug such as Flovent, and that's considered a tier 2. So maybe my copay is $18. But maybe the doctor doesn't want Flovent, they want Pulmicort. But Pulmicort on my formulary is a non-preferred. Well, I can still get it filled, but I'm going to be responsible for paying $36 of that. Sometimes some plans make the non-preferred brand drugs based on a percentage of what the cost of the drug is, so I may be paying anywhere from 30 to 45%. The same with specialty. So like specialty drugs in like Medicare D plans, the consumer is responsible for 33% of the drug. The difference between a 4-tier and a 5-tier is it kind of just shifts. You have your lowest copay generics, Tier 2 is your highest copay generics, and everything just kind of shifts down. But understanding copay drug tiers, you can find sometimes win-wins to help your patient be able to afford their medication. Hopefully you get reimbursed okay, but it can be a win for that. So we've already talked about prior authorizations and copay drug tiers. The other thing is, just remember, under Medicare Part D, some drugs are not covered by Medicare Part D, and they're listed there, such as non-prescription drugs, erectile dysfunction drugs, cough and cold medications. Sometimes if they do have PACE, some of those drugs may be covered. And some drugs don't get billed through Medicare Part D, they get billed through Medicare Part B, such as your diabetic testing supplies, your weight loss medications, immunosuppressant agents, sometimes cancer agents, and your nebulizers, such as ipratropium or albuterol. As I said before, drug costs count anywhere from 11%, but if you include specialty, that can be anywhere from 17 to 20%. So unfortunately, every year, people are trying to cut reimbursements, and a lot of times we do have to fight for making sure we maintain those reimbursements. The other thing that I'm going to be posting another lecture that I taped several years ago, and that lecture is going to be talking about Medicare star ratings. And I did talk about it in Pharmacy Practice 6, but you can take a look at it. But as I said before, we're going more to a value driven type of healthcare system. And one of the things that's happening in this value healthcare system is a lot of our health plans are being graded by different entities. So, for example, Medicare Part D plans are being graded by Medicare on star ratings. And things that they're looking at from a medication side is medication adherence and medication safety. And so, some of the things that has occurred with this is that a lot of times this is being passed on um, to the consumer, all right, and to the pharmacy. And so, what should we know as a pharmacy owner? We should always be on top of what are these different changes that are occurring in our value based healthcare system, because sometimes they can determine us. One of the things is that you're seeing a trickle down effect that a lot of these Medicare D plans are now grading us. So we have to develop adherence programs within our pharmacies, and there's various different ways to do that through getting somebody to get all the prescriptions filled at the same time, med reminder phone calls, offering pill boxes or maybe special packaging to those patients for that. I There's a good article about Medicare star ratings that I gave you in Pharmacy Practice 6, but I'll post on our Blackboard website for entrepreneurship. But what happens in Medicare Part D plans is they're being graded by Medicare, and based upon what their star rating is, it determines whether or not they are going to be able to stay in Medicare to offer their prescription insurance. Also, it also affects their reimbursement. And so what you see is, like I said, they are measuring different quality measures, and they're passing and they're weighted. And so why prescription drugs fall a big place is they are a heavy weighted outcome. And it's not hard to go from a 3-star to a 5-star. This PDC stands for portion days covered, so that's insurances. But you know why does everybody care about this? Look at this one study looking at adherence with diabetes medications. Notice drug costs go up. However, look how significantly expenses for medical expenses go down. And so that is one of the reasons why these ratings have come into play, and they're probably going to be part of our healthcare system for a very long time. The reason why I've given this example in class before is that what you pay for a drug versus a hospitalization is a lot cheaper than paying for one hospitalization. Same with why we look at high risk drugs in elderly in these Medicare D star ratings, is that one fall is more expensive than one preventive. We're actually, a lot of our contracts, besides that AWP minus such and such, as I showed you earlier, is that we are seeing maybe incentives for increasing our reimbursement for that. Unfortunately, some are creating contracts that may be penalizing us. There's a contract out there for 2016. You did not have to accept it to stay in the program. They're testing it, but basically you may get paid a little bit more if you do very well, but they're actually going to take away the money initially from you, and you have to earn it back. And the other thing is, well, why it's important to always be on top of this stuff is a lot of times independent pharmacies sometimes can get excluded out of some of these contracts, and we're always fighting that we need to be including these contracts, especially federal and state contracts. But one of the things that to be included in those, we may have to be very good at how we deal with patients with adherence and other clinical services that we can offer in our pharmacy. This hopefully all trickles down to helping the patient, improving clinical outcomes and safety. So, as you are thinking about your pharmacy business, think about how does your pharmacy business provide value? What is it going to do to be able to be a win-win for patients, employers, and health plans, and our national health plans such as Medicare and our states such as Medicaid? So we constantly have to be thinking about that. So hopefully this was a good refresher of understanding insurances. Please feel free to email me if you have any questions. Thank you and have a good day.